Good afternoon, and thank you for joining us for the relaunched Li Ka Shing Knowledge Institute's clinical and population rounds, and the second talk in the series on ending the practice of race correction in medicine. We welcome staff, employees, patients, and those from other organizations. For more information on the topics, please visit our website, and there's the link in the chat. Let me also acknowledge our partners and organizers. In addition to myself, the organizers of the event include Amy Katz, Lana James, Jamal Demeek, and Anne-Marie Fox. Our partners include the Knowledge Translation Unit at FAAP Center for Urban Health Solutions and the Canada-US Coalition to End Race Correction in Healthcare. Let me now introduce myself, and especially since it is National Indigenous Peoples Month, I'd like to share a land acknowledgement. I am Pat Ocampo. I am a professor of public health, and I hold a Canada Research Chair in Population Health Intervention Research. I'm also the Executive Director of the Li Ka Shing Knowledge Institute here at Unity Healthcare. I'll also share that I am a descendant of a Japanese mother and a father who is Indigenous North American from south of the Canadian border. Here in Canada, I am an immigrant. I'm a guest on this land, and I'm grateful to have the opportunity to work and live in Toronto, which is the traditional territory of the Haudenosaunee, Anishinaabe, Chippewa, Wendat, and recognized most recently as the territory of the Mississaugas of the Credit First Nation. Acknowledging the land means acknowledging the long history, a few hundred years, of colonization across Canada and the ongoing struggles and resistance of Indigenous peoples as they seek to gain respect, recognition, and their rights in the face of ongoing powerful forces of colonization and white supremacy. As we are a Catholic hospital, it is appropriate to acknowledge that Catholic organizations had a dominant role in the history of colonization. Colonization across North America is also a theme for the topic of this series. Racism was and is a key enabler of colonization in North America, and racism in science and medical science was and is a key enabler of sustaining the ideas that keep colonization alive, including in the form of the practice of race correction. At Unity Health, as an organization that is committed to uncovering and eliminating sources of systemic racism, this series on race correction is a conversation that we need to be having, especially the topic of today's talk about where to begin to eliminate the practice of race correction in medicine. Unlike many topics that we often encounter in rounds, this series is meant to be a deep dive into race correction, how it came about, why race correction is a form of anti-Black racism, why and how racism is pervasive in science and medicine, how race correction and racist ideas show up in different medical subdisciplines. Of course, we can't cover those topics in depth during the talks and the Q&A exchange that we have with you, so we send you a curated list of references for you to read to go deeper into these critically important topics, because race correction causes harms to Black patients. But until recently, it is a topic that has been under the radar, and we want to create a space where you can ask questions and get truthful answers. Through this ongoing discussion about race correction, and by joining in the efforts to eliminate race correction nationwide, as we'll hear about today, we can eliminate this practice and begin to dismantle one source of systemic racism in healthcare. Now, I know not everyone here knows what race correction is, and while I urge everybody to read the documents associated with this talk, let me take 1 minute to describe what race correction in healthcare is. Healthcare providers often use tests to assess a patient's health and make decisions about treatments or referrals. In some instances, healthcare providers calculate test results differently for Black patients than they do for everyone else. Healthcare providers may also use different criteria when deciding whether or not Black patients are good candidates for specific surgeries. In addition, they may use criteria when deciding whether or not the symptoms Black patients are reporting require treatment. They do this based on an incorrect and racist assumption that Black patients have inherent biologic or genetic differences from non-Black patients. These are examples of race correction in healthcare. A harmful practice, which is also referred to as race adjustment, race modification, or race norming. Race correction can occur at many different points in a Black patient's healthcare journey and across different specialties, physicians, and healthcare providers. And there are serious health consequences of race corrections in healthcare. As we noted, it's based on the old discredited and racist idea that Black people are inherently biologically different from white people. Healthcare professionals hold these ideas as they are taught in medical schools, as you have or will read in the papers that we shared with you with the invitation to this talk. So if you're a provider and you hold these ideas, one reason may be that you learned it in medical school, but another reason may be that the general public also holds these inaccurate beliefs. So let me take a minute to share a question we received in advance of the talk. When you signed up, we asked if you had any questions. And the question was, are there possible physiological differences in race in different disciplines? For example, respirology, where taking race into consideration would be justified? Or is this never the case? So the answer is that if you are taking race into account because you believe that there are inherent genetic and biological differences between races, that should be considered, for the purposes of treatment or diagnosis. The answer is that you should not be doing this. This is a false belief, and you should not be using this in making decisions about patients. So we're hoping you can use this series to update your knowledge around race, genes, and biology. Another question that we get is about data, and that the healthcare data show gaps by the variable race. And if we see these gaps, this must reflect the idea that there are biological differences by race. We should really be cautious in interpreting those gaps that we see in the data without consulting biological and social theory. And we just noted that the theory, genetic and biological, demonstrate that there are no inherent biological or genetic differences based on the social categories of race. Moreover, many of those studies demonstrating race differences often fail to account for other measures associated with race, such as income, social determinants, that might be responsible for those differences. So please keep that in mind. Now, we thank you for those questions as they help us deepen the dialogue around these important topics. Please do continue to engage with the speakers and the series by putting your thoughts and questions into the chat. We will have a 30-minute Q&A after we hear from our speakers, and the chat will be monitored by one of our teams so that we can address them in the Q&A. If you don't have a question, but you have a reflection, just throw it in the chat. We definitely want to hear from you. So you should know that we're slightly changing the order of speakers just a bit. After we finalized the speaker lineup of Dr. Opara and Ms. James, we were fortunate enough to learn that Dr. Chris Simpson could join us to comment on this issue of race correction in Ontario, and we'll briefly hear from him first. So let me introduce Dr. Simpson. Dr. Chris Simpson is an Executive Vice President, Medical, and Chief Medical Officer at Ontario Health, the provincial agency overseeing Ontario's healthcare system. He works clinically as a cardiologist at Kingston Health Sciences Centre. His clinical and research interests, and he's quite prolific, by the way, include access to care and medical wait times, atrial fibrillation, and cardiac resynchronization therapy. So, Dr. Simpson, I'm going to hand it over to you.
Thanks very much. I'll check and make sure everyone can hear me. I'm really pleased to have the opportunity to speak today. And I do intend to be brief because you're about to hear from the experts who will be leading the effort to de-adopt race correction across Ontario's healthcare system. And they'll tell you everything that you need to know to start the process. As Pat said, for the last year and a half or so, I've been the Chief Medical Officer at Ontario Health, which is the new provincial agency with a mandate to oversee healthcare delivery in Ontario. And unfortunately, we've been doing a whole lot of COVID crisis management stuff and less than I would have liked in terms of healthcare reform and transformation. But we're now really starting to get in this space. And what we're learning about today, I think, is an extremely important piece of work that needs to be at the forefront of our considerable transformation efforts. I'm just between cases right now. Today's pacemaker and defibrillator day, so I'll do my best to stay until the end of these rounds, but I may have to go a little bit early because I have to go as soon as the next patient is ready for me. So I'll quietly slip out if I need to, but hopefully can stay for most or all of this. Over the past few years, I've learned about race correction and how it affects Black patients. And it's been painful to hear and painful to understand that I've been part of a system that is set up and programmed to do a disservice, and often a grave disservice, to some of the people that I have committed to serve. The thought that someone would come to me for help, that they trusted me with their care, and that I may have done them a disservice is a harsh and very sobering revelation. And this was invisible to me before, because like many physicians, I trusted my education. I didn't know that race corrections weren't grounded in scientific evidence. I believed it was the right and proper way to serve my patients best. But to be clear, race corrections are not grounded in scientific evidence. And I know some of you will be tempted to find a scientific rationale for what we've been doing all these years, because certainly I was. But that rationale simply does not exist. Race correction is an expression of scientific racism. There's no need to look beyond that, because racism is simply all there is to this. Race correction harms Black people and communities, and this harm has been going on for years. And that's a difficult reality to confront, but together we're going to change. I am committed through my Ontario Health role to work to end race correction practices in our healthcare system. To prepare for the changes ahead, I would encourage you to study the materials shared in advance of this session, to attend future sessions, and to continue to work to end these practices in Ontario and elsewhere. This will be a long road, but I do want to commit my support as you move forward with this very complex work of safely and systematically undoing these long entrenched practices. I'm very honored to be working with you to end race correction in Ontario and in our healthcare system. And I have no doubt that Ontario's clinicians will rise to the challenge. So thank you once again for having me today.
Thank you so much, Dr. Simpson. Really great to hear from you. It's the perfect setup to hear from our two keynote speakers to talk about where we begin to undo race correction. It is a complex process. It isn't just a matter of having information in your head now that you shouldn't do it. It will be a long and complex journey. So let's hear now from Dr. Ijeoma Nnodim Opara, who is a double board certified physician and assistant professor of internal medicine of pediatrics at Wayne State University, a School of Medicine, and Wayne Health. Her mission in life is to dismantle white supremacist delusion by eliminating anti-Black racism in medicine, healthcare, and public health, while centering and celebrating Black brilliance, abundance, and joy. She is the founding director of the Health Equity and Justice in Medicine Initiative, co-founding director of the Wayne State University Global Health Alliance, and co-creator of the Global Urban Health and Equity Curriculum for Resident Training at Wayne State University's School of Medicine. She's a member of the White House Office of Public Engagement Healthcare Leaders in Minority Health, where she advises on anti-racism, health justice, and health equity. Dr. Opara is a speaker, consultant, coach, and facilitator, and hosts a weekly Twitter Spaces Roundtable, Anti-Racism in Medicine Action Roundtable, AI Mart, a transdisciplinary community of Black leadership to eliminate anti-Blackness from medicine, healthcare, and public health. As Dr. Opara is speaking, we encourage you to share any insights and learning that you're having in the chat. And I should also apologize to those who were expecting ASL translation. Unfortunately, at the last minute, there was a conflict in scheduling, so we could not have those translators join us today. Dr. Opara, I'm going to turn it over to you.
Okay. See me and hear me?
Yes.
Wonderful. Awesome. So while my slides are loading, I just want to thank really everyone. Thank you for being here. Thank you for the organizers. Thank you for my sister and fellow scholar, Ms. Lana James, soon to be Dr. Lana James, to all the organizers, to the institution, the leadership, just really, and of course, more importantly, the audience here today. I'm so excited to share time and space with you. And I'm very grateful for this opportunity and for the work that we are yet to embark on. We have been working on, and we've been embarking on, but the next level that we're taking it to. I want to thank you also for addressing the questions that came in, because those speak to a fundamental issue that informs the continued use of race, so-called race correction, and maintains the system of scientific and medical racism in our fields, in medical and clinical practice and education, research, policy, etc., and other work within the healthcare ecosystem. And I'm so grateful that you answered those questions, and even our previous speaker, all having to really lift up very key points that I will simply just be adding more flesh to the bones, very strong bones that they have already started to discuss. But absolutely, if you take nothing away, the very creation of the idea of race is not scientific, it's not biological. And when we talk about health disparities along racial lines, we're talking about disparities that are produced from structural and systemic injustice, structural and systemic violence, structural and systemic oppression. That's what we're talking about. Okay. And so we will get into it. Let me see how Mr. Anwar, if you could let me know if my slides are visible or how to go ahead and do that. They're uploaded. Perfect. Thank you. So I want to start again. My pronouns are she, her, and all. My name is Dr. Ijeoma Nnodim Opara. I'm coming to you from Detroit, Michigan, United States. And I want to acknowledge, I'm the director of our Health Equity and Justice in Medicine program at Wayne State University School of Medicine. I want to acknowledge this picture, and this is Miss Henrietta Lacks. And if you don't know about her, I hope that you find out more about her today. But she's the young lady in the 1940s whose cells right now have made it possible for science to be science, for medicine to be medicine. The HeLa cells, which were instrumental, in fact, pivotal, critical to creating vaccines that have saved lives, from the polio vaccine to the COVID-19 vaccines that are saving lives today, that have made it possible for us to explore space, to create medications, and all kinds of medical and scientific innovation that have saved lives, were harvested from this young lady, Miss Henrietta Henrietta Lacks from her cervix when she came in to present for treatment for cervical cancer. And without her consent, these cells were harvested. These same cells that have made many people a whole lot of money and have created generational wealth for a ton of folks were harvested from this Black woman without her consent or knowledge, and her family not receiving any justice or recompense or compensation even till today. Now, on the bottom left, you will see that her, I believe, grandson or great grandson, one of her members of her descendants, was received an acknowledgement and award from the World Health Organization to recognize the harm that was experienced by the family. However, in a just way, in a meaningful way, it doesn't really add up to the cost and the harm that family suffered as a result of medical and scientific racism, nor has it really brought to bear the impacts when we look at what humanity benefited from this woman without acknowledgement, credit, or, like I said, just recompense. So I say that to say, the speaker earlier said, I have been rendered an unwilling participant in a system of oppression and violence, right? By teaching me and telling me that as a physician or a scientist or a person in the care of others, that I'm doing good. I came into this to do good. But the very system in which I find myself being trained in and working in itself is inherently unjust, inherently racist, with racist impact in the ways that we're taught, in the ways that we practice, written and embedded and codified in our clinical algorithms, in our clinical thinking and reasoning and rationale. Because the ways in which we are organize and categorize humans are based on a system that was created to maintain a white supremacist racial hierarchy that hoards political and economic power among those racialized as white at the expense of those racialized as Black and everybody else in between. And it's so important how that is tied into the story of land and colonialism and settler and non-settler colonialism here in North America and throughout the world, and other forms of violence that various populations experience even until today. So we are made that unwilling and unwitting partner in this grand experiment of social ordering. And it's important that as we get to know better, like Professor Dr. Maya Angelou says, that we do better. So we don't create the harms that have been documented historically and currently in terms of treating humans as humans, whether it's Henrietta Lacks, whether it's the Tuskegee experiment and the treatment of syphilis in the Negro male, whether it's forced sterilization and eugenics, whether it's a whole litany and host of ills that our field has been at the forefront of throughout history and even currently. And so if you haven't read any book by Dorothy Roberts, I invite you to go do that. We'll be featuring her today in this conversation. If you haven't read any book by Harriet Washington, including Medical Appetite, again, I invite you to also avail yourself of that. And these are some of the resources we have for you on the endracecorrection.com website that we have curated. But let's get into this presentation quickly. I acknowledge the land that I'm coming to you from, the land of the Anishinaabe, the Ojibwe, Odawa, and Potawatomi, Three Fires people, as well as the history of genocide and forced removal and settler colonialism here in the Detroit or Wawiatanong or Detroit. And I acknowledge that we continue to be better stewards of this land while acknowledging and honoring my ancestors who have lived, fought, and struggled, as well as survived and thrived in order that I may stand before you a free Black African woman today. I thank you for the organizers for naming the needs for accommodation and respecting that. So again, as I mentioned, again, if we don't take anything out of this conversation, is that everybody here leaves aware that race is not a biological category. So framing questions that lies on this premise that that humans are somehow biological distinct from each other based on race, which itself is a made up figment of white European imagination in order to maintain a system of capitalism that accords and consolidates economic and political power among those racialized as white, at the backs of those racialized as black, and then others later known as indigenous, and etc. Then if we don't get that, we miss everything else. Then we start asking questions like, well, what if there's some difference? Well, the difference is not along racial lines, is the point, right? Which leads to this point right here, that racism is the vector of disease, not quote unquote race, right? Race was invented in order to support a system of racism. Racism came first and then invented this idea of race that wasn't based on biology, right? And that, therefore, when we see health disparities, or we see disparities of wealth and disparities of resource and other measures and metrics of social performance, the vector is the system of racism, and not necessarily quote unquote the racial category. And this is so key because it informs the ways that we talk about solutioning and interventions, right? Where we're not looking on the individual level and we label the individuals or the communities or the populations as inherently deficit, which is the way that we were trained, right? Black folks have a higher rate of this and the worst case of that and the other, not without context. And so then you think, oh my gosh, there must be something wrong with their kidneys, something wrong with their lungs, something wrong with their brain, some receptor that is weird and off, right? That becomes the questioning, which is the intention of that kind of thinking, so that you obfuscate and render obscure the systems of oppression and violence encoded and codified in structures of societal ordering that actually is the vector of that disparity. You ignore that, you don't pay attention, that you don't fight for justice, you don't do what needs to be done, right, from a systemic standpoint, and you're looking for epithelial changes and changes in receptors and changes in cells among the folk that were created, that whose categorization and shared experience was created through the mechanism of white supremacy. And so it's so important that we are framing the problem appropriately so that our solutions can be framed appropriately, correctly, and therefore effectively having the impact that it needs to have. And so therefore racial disparities are not accidental, but by design. And again, I always bring it back to this and reinforce this, that therefore race is not the same as ancestry. These are different things, right? The category of race shifts and changes depending on where you are. With Brazil, someone like me can be considered mulatto. In certain parts of Africa, I could be considered mulatto, quote unquote, and I use that with air quotes because it is an offensive and derogatory term, right? This idea of race shifts with geography and shifts with time. People had to sue themselves in the United States into the categorization of white. Right? At a certain part, Irish folks were not whites, neither were Italians, neither were people from the Middle East, neither were people from Mexico and other folks in the Latinx category, right? That had to be accorded to them by law. So are you telling me that their lungs change function once the court hit the gavel on the board to say that, yes, now you're white? Now, all of a sudden, their kidneys work better. All of a sudden, their blood pressure works better because they're now assigned a socio-political, socio-legal categorization. Does that even begin to make sense from a biological or medical standpoint? No. Right. And we only know this when we understand our history and we understand how things come to be. That is why it's so critical that we are grounded in a socio-ecological, socio-political, socio-cultural, socio-historical context as we have these conversations. Biology and medicine are not to be experienced or professionalized, should I say, alone and in silos. They are linked to and connected to all these other realities that then realize as health outcomes, health experiences, etc. And so myself and my colleagues wrote a paper, Modern Day Drapetomania, calling out scientific racism, to really name knowing that history and that context, right? Because we were not hearing these conversations. We were seeing papers being published in high impact journals, legitimate medical journals that were locating the issues around COVID-19, the disparities and the disproportionate impact of the pandemic on Black folks and brown folks and indigenous folks somehow on their biology. We got a paper talking about the nasal epithelial lining might be of in Black folks maybe somehow more somehow matched or just easier to be permeated by SARS-CoV-2 and other nonsense type premises in 2020, the 21st century, based on knowledge and paradigms established in the 1800s and beyond. This cannot be, right? We're launching people into space. We have all kinds of scientific and technological innovation, but when it comes to population medicine, we are still locked in the 17th century and we think that's okay. It is not. It is not. We cannot insist on advancements in medicine, technology, and all other types of science, but we are locked in the 17th century and we think that's okay. And so medicine is not a standalone institution immune from racial inequities and racism and oppression and violence and built inside of white supremacist structures, but itself is an institution within that structure. Scientific racism underpins race-based medicines by which research characterizes race as an essential biological variable, and this translates into our clinical practice and research and policy, etc., and leads to inequitable care. And again, is that presumption of biological difference, but that biological difference isn't just that, oh, you know how we're all just different flowers in the garden, you have red and pink and yellow, but we're all beautiful. No, that biological difference is to emphasize a hierarchy, that somehow this group of people are inferior and these others are inherently superior. That has always been the function of it, and physicians have always played a role. American physicians in the antebellum period, our role, or the field, not me, right, but our role as physicians was to uphold this system of white supremacy, was to uphold American chattel slavery. Physicians, their role primarily was to establish the fitness of enslaved Africans for labor, to produce labor, and in the case of enslaved African women, to reproduce labor. And that story is tied into the development of what is now the field of obstetrics and gynecology through the so-called father of modern OBGYN, Dr. Marion Sims. And I don't refer to him as the father of the field. I refer to those enslaved African women on whom he experimented and developed many of the procedures and technologies that are still used today to save lives as the mothers of OBGYN, Betsy, Anaka, and others. And so our role has always been intertwined with the creation and the maintenance and the reinforcement and perpetuation of systems of white supremacy and racism, always from the beginning. So it is beyond necessary and critical that we are at the forefront of undoing that. We must. It is indeed our heritage, and therefore calling responsibility and should be held accountable to the undoing of that through many mechanisms, many approaches, central of those being correcting race correction, so-called race correction. And I've already made this point as well. And one of the things I always like to remind folk is not to understand just a thing for what it is, but what is the function of it? What is the function of it? And as we continue to perpetuate and we get some, pushbacks, well, but again, what is the function? What ultimately is the function? And that is to uphold a system of a racial order of white supremacy that consolidates and hoards political and economic power at the top at the expense of others. And to do that, you have to then render all folks that are in non-white bodies as less than human. It is a systemic dehumanization that is interwoven with a system of capitalism, right? And racial capitalism in that end, to that end. And when we see the function of them, that is how it works. And so, how is it used? Again, as speakers before have mentioned it, in differential diagnosis, in evaluation and treatment of various conditions, in technology, in artificial intelligence and machine learning, and different medical devices. We had a discussion on our Twitter space, Anti-Racism in Medicine Action Roundtable, about pulse oximetry, in which a lot of studies from early 2000s, really, we've always known that there was differential impact in terms of the ways in which the pulse ox devices measure oxygen in darker skinned bodies, and nothing has been done about it. And it has had repercussions when it came to a disease such as COVID-19, as well as other respiratory diseases, the ways in which our resources are allocated, and the assumptions and the proxies involved. These are two papers from the Lancet and from New England Journal of Medicine, from race-based to race-conscious medicine, how anti-racist uprisings call us to act, and Hidden in Plain Sight, that really talk about the very many ways, the various clinical algorithms in which so-called race correction built and founded and homed and housed inside of scientific racism are found. And these are small for you. That's okay. Again, these are resources that are accessible to you, available to you from the endracecorrection.com website. So whether it's in kidney function, the EGFR, whether it's the BMI risk for diabetes, the FRAC score for osteoporosis and bone health, PFTs, pulmonary function tests in terms of respirology or pulmonology, as we say in the States, the use of hypertension medication treatment from the Joint National Commission 8 hypertension guidelines, pediatric UTI diagnosis, which was recently changed from the American Academy of Pediatrics, and the list goes on. And the list goes on, 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 y'all. And it keeps going on. There are very many ways in which we have embedded and codified these false, dangerous, harmful beliefs that have resulted in disparate deaths and disparate morbidities and disparate disabilities, disparate quality of life of reduction. Frankly, essentially, functionally malpractice based on nothing but false purposes that were unchecked. And so the consequences are delayed diagnosis, misdiagnosis, delayed intervention, lack of surveillance, misallocation, and wastage, frankly, of resources, inappropriate treatment, misclassification of disease severity, and access to life-saving procedures. And the Kellogg Foundation, and I'll be closing my comments in a few minutes. I see that my wrap-up is here. Time is here. The costs are really countless when it comes to the financial and economic burden of maintaining such a system, right? And we know that ultimately it's killing differential black patients. And let's be clear, if it's disproportionately harming any portion of your population, it is harming everybody. Because oftentimes people think, well, poor black people. No, this is everybody's problem. It is everybody's problem. And we could talk ad nauseum about what that means, but just, please, rest with that, And so when we talk about the dehumanization of these ways of being, it goes back to whose pain is worthy. And we know from the studies that we have internalized that Black people somehow have thicker skin and don't feel pain the same way. There have been repercussions for that. So I'm going to land my plane around where we go from here. What are the implications and recommendations for anti-racist clinical practice? We want clinical practices. We want medical and healthcare education. And please be clear, even as I'm a physician and I've talked about it from a physician medical standpoint, please understand that we are also talking about nursing, pharmacy, veterinary medicine. All right, because those animals live with humans and in families, and there are some repercussions there. We're talking about environmental health. We're talking about all dentistry, all aspects of the healthcare ecosystem. And so what would it look like to have policy, process, practice, law that is grounded in anti-racism, justice, equity, and belonging in terms of the values and the ways that it shows up by centering the margins and marginalized, complex and challenging, embracing discomfort for growth, nurturing courageous learning and practice spaces, active listening with humility and respect and commitment to change, where all individuals and populations are equally valued, where there's a strength-based abundance mindset and perspective that is embodied, where historical and ongoing injustices are recognized and rectified, and resources are provided according to need with an adherence to anti-oppression and justice principles, right? Where there's a reckoning with medical and violence, medical racism and violence, history and ongoing current events in North America and around the globe, right? And so Dorothy Roberts writes here in her paper in Lancet, Abolish Race Correction as the first step here. Anti-racism in medicine therefore requires more than weeding out bias in the minds of individual physicians. It requires ending how medicine is structured to promote racist ideas, policies, and practices, right? Moving from race-based to race conscious. And so we have organizations that have done that. We have the National Kidney Foundation and American Society of Nephrology Task Force that have changed their guidelines and removed the race variable in the calculation for renal function. We have the American Academy of Pediatrics, who has changed and removed race from their calculation for urinary tract infection for children. And there's a framework that has been proposed for appropriate anti-racist approaches to racial and ethnic health disparities research. This might speak to the person who asked the question earlier around there's 7 guidelines that have been offered, whereby race, ethnicity, disparities, and contextual factors must be explicitly considered in a study's design and interpretation, that the treatment of race, ethnicity, disparities, and contextual factors must be explicitly and systematically evaluated by reviewers with the appropriate expertise, where the potential for racism in measurement is assessed and addressed, where research focused on genetics and ancestry must be considered for historical and contextual factors, where potential bias in source data for AI and machine learning is assessed, and that the community that is disproportionately affected is engaged, in fact, centered, and that the investigator team must include those with expertise in race, ethnicity, disparities, etc. This is sufficient to say that a lot of national organizations throughout the country have come together around these ideas to impact medical and healthcare education, practice, and policy and processes, including the AMA, that we are changing, such as my curriculum, HEGM, at Wayne State, HEGM, are changing curricula on all levels, faculty development, graduate medical education, undergraduate medical education, to begin to center these ideas, where these ideas are getting embedded in our assessment and evaluation of trainees and faculty in recruitment and hiring, promotion and tenure. And these are some examples of that. They are reflected on administrative priorities, such as you know, my work with the White House on the Health Equity Roundtable, and also politically in linking this to policy and the work that's being done to address these issues on a larger scale. And certainly in the work that we're doing at endracecorrection.com, and the work that we are doing even on social media, on the Twitter space, which I hope you all can join us with at INNODIM account, to really raise these topics and build solutions and ideas. I appreciate you. I apologize for going over time. I thank you for your attention and the work that you're doing to make this happen on the scale that it needs to happen, not only in Toronto, but throughout the country of Canada, and frankly, throughout the North America and the Americas as a whole, because this will have global implications even in other regions of the world. Thank you again. Many blessings. I'm looking forward to Q&A.
Thank you so much, Dr. Opara, for sharing your passionate wisdom. Some people think that passion and science don't go hand in hand because we have to be objective, but you have proven that statement to be wrong. Certainly as scientists, we should and do welcome scientific debate, but in this case, I think the science has already been settled on this issue. There are no biological or genetic differences by socially defined race. I know that we got a question in the chat about race mattering for First Nations and race mattering for HIV/AIDS. And yes, there are socially determined differences by socially defined race, and they do matter for the issue of HIV/AIDS, for example, in the area of discrimination, but not biological race. So we need to also even take care when we're using the variable race as a social variable. We can't assume that all individuals in a social category of race have the same experiences. I also want to reiterate, Dr. Opara mentioned Dorothy Roberts and other authors, and they are important, but her article on drapetomania in the Journal of General Internal Medicine is excellent. So I highly recommend that, and we had sent that out to you. Okay, so let's move on, because we now get to hear from Lana James, whose research illuminates how technology can undermine or bolster human rights in the context of clinical care, rehabilitation science, and public health. Her interdisciplinary and applied approach is designed to critically appraise current applications of technology while developing and implementing interventions that seed new ethical futures. So to accomplish this, Lana brings together academic and community scholars across disciplines and sectors to work at the intersections of medicine, clinical care, public health, data, AI, law, and race ethnicity across multiple axes. As a result of her groundbreaking work, she is the inaugural AI Medicine and Data Justice postdoctoral fellow at Queen's University. So put your thoughts in the chat, please. Continue doing that. And after Lana is done speaking, we will start our Q&A session. Lana?
Hi, everyone. And I want to say thank you for joining us. I really appreciate you being with us today. And I hope that you're learning as much as possible and that you're putting your questions in the chat, because we will look forward to answering them. I'm just going to recap a few points, because I think both Dr. Simpson and I think Pat, as well as Ijeoma, did an amazing job of making sure that you had a really good background. And my job here is to kind of tell what happens next. And so, as you know, this is the Canada-US Coalition to End Race Correction. I am your Canadian co-chair, and Dr. Ijeoma Nnodim Opara is the US co-chair. And the reason we have united together in the Canada-US process is because, in fact, as you know, the United States publishes a large number of the articles, journals, and sets the standards globally. And that's important to understand, because there's always the business of medicine as well as the practice of medicine. And so we want to make sure that our efforts tie into the efforts of students on the ground, other societies, activist groups, patient advocates, other clinicians that have been pushing for a very long time. It's important to know and to understand that this is not a new issue. The oldest parts of race correction have existed for 160 years, and that is in the practice of respirology, as we say in Canada, or pulmonology, as they say in the US. And some of the more recent ones have been developed as a result of irresponsible artificial intelligence. And so it's important that we understand that, one, you know what race correction is. And today you also know that it's happening. It's happening here in Canada. It's happening systematically, because that's what you were trained to do. I have the privilege of also participating in curriculum overhauls and reviews. And we know that in the medical schools, all 17 of them across Canada, race correction is alive and well. And it's alive and well in the practices of their preceptors who are taking on residents and fellows. And so now that we understand what race correction is as a definition, and now you know what the stakes are, we also have to understand what the stakes are for clinicians, their institutions, licensure bodies, and advocate groups. And the stakes in this sense are around change, about making transformative change and doing it now. Through the pandemic, many Black folks have described being turned away from emergency rooms. Often the oximeter was put on their finger and they said, "Oh, you're fine." Meanwhile, the patient was failing. I myself have been involved in several instances where close members of my community almost did not have a chance to make it because of the practices of race correction and inappropriate use of devices that should be called defective, but for now are not. And we're looking again to our communities to push back and make sure that those devices are listed as defective. And that's one of the actions coming out of the work that we do on Saturdays on the Twitter space. And so we've already also heard that it's important enough that we're looking at moving and changing those quality standards. Dr. Simpson, a practicing cardiologist and executive vice president, chief medical officer at Ontario Health, gave us some thoughts and reflections on what it means for many of you as clinicians and for us as researchers and scientists to identify and understand that there's something that we learned that is not only harmful, but in fact has to stop immediately. And that he's making that change and supporting his entire team in making that change and voting for all of us to do it effectively and efficiently. So my role for you today is to do one thing, is to make sure that we understand that, A, please don't go run off and do this. I want to point out something that a Black person who has had the unfortunate experience of race correction, not just in one organ system, but multiple, and said, I can't understand. I thought we had a really good relationship. And I explained to them that this was the way physicians are trained. And they said, and now I'm supposed to believe that this person who didn't read articles that have been around for a long time is now going to turn around and help me. And we're constantly being gaslit around issues of trust. That's mind-boggling, and it's terrorizing. And how come they get to do that? And the answer is we don't. And so we're not going to be expecting the people who have already participated in the harming patients, as unconscious or unintentional as it may be. We are, in fact, setting up and have set up, I've worked on this with other colleagues for 3 years, identifying and laying out a plan so that we have a place to start and to move forward from in terms of enrolling in cohorts. And so we're going to do this together safely. We're going to do it together systematically. We're going to do it with a clear view and transparency, so it's clear to everyone, both that is receiving and has received race medicine and those who are practicing it, that not only is anti-Black racism in medicine no longer acceptable, it never was if we acknowledge the human rights conventions, but we're going to make sure that it's removed from not only the patient experience, but from the clinical research. And we're going to do that by engaging it in a systematic process of de-adoption. And de-adoption is the process of removing a clinical practice that is not therapeutic, has been found to be harmful, or another practice of the clinical space can accomplish the outcome much more effectively. And so I think it's really important to understand that race correction meets all three of those items. And so we're going to be undertaking de-adoption and improving health quality, health assurance. And we're also going to make sure that we also improve our implementation science processes for the adoption of the more effective practices. And so I want to leave it there so that we have time for questions. And just to recap, the first thing you're going to do is you're going to go to endracecorrection.com and you're going to pop your email in there to subscribe so that we can give you the information on how to do pre-registration and to involve and get the rest of the materials and participate. You're welcome to participate if you're a medical student or fellow, if you're in a teaching or non-teaching or community hospital, if you're an individual physician and you're able to move, but your department or larger health system is not, if you're a nurse practitioner, a pharmacist, and most important, if you're a direct clinician, a dialysis unit manager, or a research coordinator, please subscribe, email, and we will enroll you in the steps and give you more information. There will be a full workshop. Thank you very much.
Thank you so much, Lana. And to all the panelists, what I love about what we're talking about today is not just the problem of race correction, which is a really big problem, but some really concrete steps on what we need to do as, practitioners, researchers, to begin to undo race correction and to address some of the racism that we tend to see in science. So we are going to hold the Q&A now, but actually, because I know that Dr. Simpson may have to leave to go tend to his patients, maybe I can hand the mic over to him to see if he has any parting reflections. Dr. Simpson.
I appreciate that, Pat. Well, I feel like I've really just attended a master class, and I have had the benefit of having many conversations with Lana, and have benefited from her brilliance and wisdom and expertise, which has really helped me to understand this issue in much more depth. And I really have come to understand that understanding the deep roots of anti-Black racism in medicine and in our healthcare system really is a prerequisite, I think, to understanding how we've gotten to where we are today, and is required in order for us to understand how we're going to be able to move forward. And as I've said, that is a tough message for us to hear, for those of us who've taken the Hippocratic Oath, where we've said, among other things, that we honor our teachers and our predecessors in medicine. But this is one systemic sort of piece of our education and our history that we should not be honoring. And so it is a difficult departure, I think, for professions like healthcare professions to actively challenge these sort of time-held beliefs. And I really can't say it enough. And I know that this is also a difficult message for many people new to this discussion to hear. But race is a social construct. There are no biologic differences based on these social constructs. And I think both of our previous speakers have emphasized that, if everybody can leave the session today, at least willing to explore the truthfulness of those statements and to start to question some of the historical truths, what we believe to be truths, that will be the first journey in helping to advance what we're trying to accomplish. So back to you.
And thank you for joining us, and just thrilled to know that we will be doing something in Ontario, Ontario-wide about this issue. Again, not that it will be easy, and that's why we want you to sign up for the Ending Race Correction Coalition so that we can do this together. I think we'll do a better job if we end up doing this together. So thank you for joining us, Dr. Simpson. Okay, so now on to the Q&A. So we've gotten some questions in the chat, and just scrolling here to see where that first question is. So one question is not quite about race correction, but I think relevant for this discussion that we're having here about differences by race. I think we need a lot of reminders and a lot of explanations for how we should interpret differences by race. And the question is, in Canada, Black people have better care and equal health care. And so I don't know if one of the panelists want to address that. Wonderful, Dr. Ijeoma, would you like to take that one?
Well, I'm going to just offer a general reflection and then defer to my sister and co-chair here in terms of the Canadian more specifics, because we've had this conversation, extensively. And I put this in the chat here, but it may or may not be visible by the audience. So what we're talking about, again, is the true. Even though I'm coming from a U.S. perspective, this is a very real issue across North America, and certainly with the United States and Canada. And we know that it's also a global issue as well. There are many ways in which medical racism shows up within the healthcare system in Canada and in the United States. We've talked about a few, but primarily, particularly for the purpose of this conversation, is through use of race correction in clinical algorithms, in clinical decision making, where it comes to evaluation, management, treatment, etc., and allocation of resources. We've seen this with ventilator use, the use of devices. It is codified in the very ways in which we practice healthcare. If that is codified in a way that is inherently therefore biased, it's going to have those biased outcomes and disparities that we observe. That is happening by and large throughout Canada as it is in the US. So ipso facto, the outcomes are inherently disparate. So to state that, well, we have equal healthcare in Canada, I don't know that that's based in data, or what we know from data and what we know from the ways in which specifically race correction works is that cannot be true. If you are treating your Black patients, a nephrologist or a primary care doctor, for example, is making decisions about referral for dialysis and care of risk factors that contribute to chronic kidney disease, referral for transplant, based on a number that used a calculation that treated that person's race as a variable, then that person is already being subjected to a disparate care that will have disparate outcomes in terms of their lifespan, how long they live, how well they live, and if they live at all. That is not equal care. So I think it's important that we understand how this shows up. And this was sort of like the speaker said, it's a masterclass. It's sort of like a rapid fire round. And we're looking forward, part of the coalition to the Canada-US Coalition to End Race Correction in Healthcare, is to have these conversations in smaller bites that can be richer and deeper. I understand it's tough to wrap our minds around because we are so embedded in the training that tells us one thing, and we're here to tell you that's not true. It takes a minute, but I want to reassure you that that assertion is not actually correct. But let me ask Lana to share some more details, as she's based right there in Canada and been doing this work and has some data for us.
I actually think you did an amazing job. I think that you covered it quite well. I mean, we've been talking for some time, and we've been having some in-depth discussions and having online workshops. And so I think you did an amazing job. And I'm going to give the floor so that we can have even some more questions come through. Thank you.
Sounds good. You know, maybe I'll just add one thing, and that is we don't routinely collect race data in our health records here. And so we don't always see where there might be differences caused by social processes, that is racism and discrimination in the healthcare system in Canada. But the few studies that have looked at race and health outcomes show the systematic differences, but showing that Blacks are at a disadvantage, and they have poorer health and they do receive worse care. So again, we can't systematically show it or show it as often as we do for the US, but that's further support that race correction and other processes in the healthcare system put Blacks and their health at a disadvantage. So the next question then is, here we are. We have been taught that certain populations have higher risks of specific conditions or higher incidence of specific conditions. Are you saying this is due to socioeconomic versus biologic factors?
Lana, please.
Yeah, I do think that it was covered, and the question may have come in as it was being answered in Dr. Opara's presentation, but it's always important to reiterate it. And we get this question over and over again, and it's because you've been taught it over and over and over, the incorrect answer. And so when you drill the incorrect information into someone who spends 15 years studying and practicing, it's difficult to come out. But I will reiterate, the higher incidences, these language of risk, are all misframed, and we could use the word misinformation, and now that you know better, it's disinformation. Mm-hmm. And we can say that because there's not a scientific basis for the problem lying in the quote race of the individual. What we know, and I encourage you to read a book called Maladies of Empire. Maladies of Empire is a very important book, and it's an important book because it's written about how physicians got their knowledge through enslaved people. It's also about how epidemiology came to be, and the way we language categories and the way we create categories. And what we know about earlier practices is the scientists were actually a bit better back then. Some of the doctors, they actually recognized that, if you don't have good quality food, and you don't have good quality air, and you don't have good quality water, and you're constantly being put in oppressive and violent situations, surprise, surprise, humans don't do well. And so it would be irresponsible to attribute socioeconomic and socio-political processes that have existed for greater than 100 years. And remember, for Black folks, let's be very clear, the system of racism is global. I could literally go to Japan right now. I could go to Madagascar, and I would actually still experience race correction. you got to ask yourself, how does it travel? It travels because racism is in direct relationship and a tool of colonization. And so what you've been taught is to dismiss the facts of evidence, which are mountainous. And what has been done is a lazy type of science where we just go, oh, that's Black people. No. And we know this how? Again, the historical record tells us many of your Franciscan, Dominican friars and monks wrote extensive records, descriptions and drawings about our health, our teeth, our vigor, our respiratory strength, our lack of cardiac issues, the lack of cavities, amazing skin. So all of the things that attribute to health, and having never had those. And we see that as well with the Maasai, who have been recently pushed and shoved out of their territories, who were always described as a little bit in a way that's not so comfortable, as a marvel of health, are now experiencing the same things that Indigenous peoples who are displaced experience, and they end up getting diseases of colonization. In the past, they were called diseases of civilization, but we know that colonization is anything but civil. And so to your question, leave aside the disinformation and misinformation and take those tables and then actually look at the real research instead of what someone is telling you. I hope that helps.
Thanks, Lana. Okay, next question. Are there any efforts to address race correction in the accreditation and appointment processes for physicians and healthcare providers?
Should I go in that one? So part of the work of the coalition and why we formed the coalition is to do two things. One, to lead by example. You'll note that Dr. Opara is an MD and I'm of the PhD version, and that's for a good reason. One of the things that you'll notice consistently is that all the folks who have drunk the Kool-Aid, in this case, the Kool-Aid is anti-Blackness and racist science, should not be in the room together. We need people from outside the discipline in which folks have been brainwashed to be able to intercede, right? And so that when we think of things that are normal, because like everybody else, I mean, she's not just certified once, she's double certified, right? So she's gotten a double dose. And so I'm there to also balance, because I have actually led, been a director of, and managed healthcare organizations and provided consultation for healthcare systems. And that is the way in which we are best to do the undoing. And so the key part here of the undoing is immediately we've triaged the situation. We are dealing directly and most importantly with hospitals that are immediately caring for people. The pandemic was devastating in what I witnessed. It was absolutely devastating to see race correction and racism in clinical care and really poor clinical tools like the oximeter consistently leading to harm. And I want to point out, if you go and check your research, those numbers about, quote, Black folks having high rates of COVID in the US, in a very well-written article, were attributed to the state of the receiving hospital having low to no resources, having low to no supplies of PPE, which, like Canada, were given out in a racial hierarchy. And this was told to us directly by the nurses who were on the floor, for whom their own bosses and institutions would not listen to. We also know from this investigative reports that the low staff numbers had been chronic prior to the pandemic due to the underfunding of the institutions and health systems. We also know that there were not enough rooms with the right equipment, and the triage protocols were quite severe. So the death rate for Black folks to COVID who were received by health institutions, which the majority did seek out, was the result of a health system and clinician-induced harms. It wasn't their biology. So let me repeat that. There is no evidence, including those ridiculous claims that having more than one condition was going to predispose you. No, if we get good clinical care that is equal to those who received it, affluent white folks, then we have similar outcomes. Because surprisingly, a lot of the white folks that did okay had more clinical conditions than the average Black person. Yeah. And that is why we say, watch what you read, because a lot of times, including in peer-reviewed articles, there is misinformation fed right in and it gets right past. So to your question, we are working to reach out to and continue to work with the licensure bodies, the accreditation, and curriculum. And this is a long haul piece. Start on this some time ago. So you will be seeing some webinars, workshops, you will be seeing CMEs, and you'll be seeing them with some of the key bodies in medicine across the country. We are already working with several large teaching hospitals, as well as community hospitals, as well as specific trauma centers. So we are, in fact, moving on and pulling things in, and we like to do things in a way that is as voluntary and as insightful as possible. But as Dr. Opara pointed out, in our meetings with our US partners and with our legal teams, there is a time limit to how long we can wait for people to stop causing harm, because it has led to increased amputations, increased death, loss of productivity, loss of work, and higher insurance rates. And so the cost of white supremacy continues to fall on the books and lives and bodies of Black people.
Thank you, Lana. Okay, the next question might have been answered, at least partially. It sounds like this is a structure problem, not just a practice problem. So we need to address it structurally. Is that correct? And what does that look like in practice? And you've already mentioned, for example, how this is going to be addressed in teaching. And already trying to create efforts to remove it from practice as a whole through undoing some of the race correction that's done. But maybe you want to add to that?
Yeah, I can add to that. Thank you for that question. Great question. Absolutely. It's a structural problem. It's a systemic problem. It's a practice problem. It's a cultural problem. So it is a problem that operates on many fronts at many different levels. And so we do want to address it systemically. And so, yes, there is the unlearning and the uneducation, sort of untraining, the deconditioning that is part of, for example, today's session, where you didn't know, but now you know. And when you know better, the expectation is that you do better, and that you can take that back. Each and every single one of you is part of that, answering that question, which is that you take it back to your classrooms, to your rounding teams, to your clinics, to your hospitals, to your kitchen tables, to your, when you're hanging out in the bar or wherever you are in the park, and you're having these conversations and you're asking those questions to your physicians if you are a patient, or if you are a caregiver of someone who is a patient with a healthcare provider, that you're having those conversations with them, and they're asking them, in what ways do you use race correction, and do you understand the harm that is being done as a result? And these are the ways to make those corrections. So when we talk about systems and structures, people constitute the system and structures. People maintain them and perpetuate them, and as well as benefit from them, as even as they're harmed by them. So these things speak to each other. But as Lana talked about, we are definitely addressing it from a structural systemic standpoint through the accreditation aim, through recruitment, retention, hiring, promotion, tenure, evaluation, and assessment, as we've talked about, through leadership, working on accountability structures, guideline changes, and so on and so forth, via the various national and local healthcare organizations and societies. So these are some of the few ways. But I want you all to be encouraged that even as we are doing the work on the levels that we are, each and every single one of you are advocates. Each and every single one of you are change agents and leaders, and you can make a change. You can add. I always talk about the tidal wave of change. Is made up of little ripples. As I do my little piece, and you do your little piece, and they do their little piece, it all adds up to this grand tidal wave of change. And so it might seem monumental, but just do your little part. Even just tell one other person about this. Even you divest from utilizing race correction algorithms and equations and clinical reasoning. That is a ripple that adds to this tidal wave of change. And that's how we get it done.
Thank you. And here's the perfect follow-up question to that. And it says, we know we will face resistance to change. How can we deal with this resistance so that we can move forward?
Lana?
Yeah, I'll be glad to take that question. And it's a great question. Part of the reason the way we're speaking to you today is part of a long thought out strategy about how do we address that. Having worked in the healthcare system for a very long time and been in leadership roles, both on the public side and in the corporate space, The power differential across organizations when someone's ready to make a move and when other people are not is a serious concern, especially when we're talking about de-adoption of a clinical practice that's known to be non-therapeutic and also harmful. And so often we see when it comes to change, the literature also shows you that people that are in less states of power are more apt to move forward with change, and folks that are more entrenched and have more power and seniority typically are less likely to be as urgent about that change. And part of the reason we formed the coalition, and our coalition members are from all different kinds of leadership spaces in organizations and also from the front lines, is to begin those conversations long before the actually you experience this. So I've been running around, having conversations. Part of how Dr. Ocampo and I come to work together is having that conversation. What would it mean in terms of research? Unity Health happens to be one of the most prolific research sites. So how do we stop the publication of mis and disinformation around continuing to publish and submit articles that are baked into racist science? How do we stop that? Well, she happens to be the executive director of one of the largest dry bench research facilities in the country. And so we address that. We begin to talk that through and say, so what happens if this happens? And luckily, I've had, along with a lot of my partners, experience with working those things through in advance, providing alternate processes, and also independent third-party routes to articulate concerns so that they can be addressed diplomatically and delicately. And sometimes we got to go straight in there. And we're not conflict averse either, but conflict is also a good thing. So know that the reason the coalition exists is because this is not just about, as we said, and as many of you have already recognized, simply changing a guidelines. It's connected to a patient's prescriptions, their claims, their insurance, other needs that go beyond the clinician. And so folks that are not the direct attending clinician or may have other roles have a role to play, and they may want to speak up, and we're there to support you. Like we said, we're talking about the doctors right now because we're at Unity, but we're talking to the scientists, the nurses, the dialysis support units, the social workers, because scientific racism has taken everybody to lean in. And we need everybody now to lean back from the racism in science and lean into the process of a critical transdisciplinary implementation science de-adoption national program that we have gotten the groundwork, we've got the resources. Now we get into the finer tune of the co-design for very specific customized implementation at local sites. So we got you.
Thank you. The next question is, should race correction be removed from the patient charts, and should articles that embed scientific racism be retracted?
Yes, the answer to that is yes, absolutely. They should also be removed from laboratories which do the specimen processing that are sent to them, and oftentimes actually conduct the calculation and then report the responses. Right now, even though the NKF and ASN has changed their guidelines, one LabCorp has adopted that change and is not reporting using the race variable, but the other one, Quest Labs, I believe, as far as I know, still is. And so we have to be thoughtful about the whole entire ecosystem. Again, this is a whole healthcare, whole medical academia approach. Every member of the ecosystem needs to be touched as it relates to this. We have race correction in dentistry. We sometimes forget about dentistry. We talk about physical therapy and occupational therapy, speech therapy, neuropsychology, psychiatry. Oh, psychiatry. That's a whole different topic. And every sort of area of medicine, but also health care and public health. So to your question, absolutely. The lab setup, the electronic health record and chart setup needs to be de-adopt race correction and other forms of bias and racism that are also embedded in the setup of these these devices or systems as well. And absolutely, we have fought for the retraction of articles that have treated biological race as real when it is not. And I will tell you that the anti-racist framework for research that I shared, which is in the AAP's journal, I forget what they're called, but I'll send that to pediatrics. That is the AAP's journal, and all these resources will be on our website, and they talk about, how to be, to be critical when it comes to the use of race, ethnicity, and ancestry data. And so we have guidelines. It's a question of instituting them. But we, the consumers, have to hold accountable. And the key word here is accountability, right, of these systems to ensure, because a lot of times, and I'll tell you this as an educator, I'm not one of those educators that think people don't know. Oh, a lot of people know. They know. But people are not going to change until oftentimes they're made to change, right? And so accountability is a key piece of that. And so because it's just more comfortable to be complacent and maintain the status quo. That's one of the questions that came and said a lot of people benefit from the status quo. It's comfortable. And if you're benefiting, why would you change?
Yeah.
So one of those pieces is working with the publication industry, editors and other members of the publication ecosystem to put checks and balances to discourage the submission of articles and manuscripts, working with funders to discourage accepting projects that treat race as biology and are decontextualized of the socio-political dynamics that inform disparities along racialized populations. And so that is a great question, and we can all do that individually, even right now.
Thank you. And I would add that if we can't get the articles retracted right away, another tool to use is to write letters to show how there's faulty assumptions in those articles. And I think that is a good tool. It's not about calling out bad people. It's about calling out bad science.
Exactly. Absolutely. And there is a tool known as what is CARMEL, critical appraisal of research in a medical literature, critical appraisal of the use of race in medical education literature, CARMEL. And
Right.
we've done work on that in our workshops in the Anti-Racism in Medicine Action Roundtable. And so those will be part of the resources we will include on our website as well. And that is a good tool. And so if you're writing a letter to the editor or you're writing your own article, you don't have to wait for a letter. You can write your own perspective paper. You can
Yeah.
write your own, just off of this conversation. You all can go and write. And that's a good tool to give you language, maybe to frame your feedback of the work that you are criticizing.
Thank you, Dr. Opara. Okay, so next question. How do we deal with the fact that there's no direct oversight over patient care?
Well, that is an excellent question. It ties into so many other things. One of the wonderful things about the coalition and the work that we have laid out, that has been laid out for us by Scientific Racism, is that the center of this is around improving the quality of clinical practice and the science that goes in it. And improving the quality of clinical practice means also improving the ways in which patients, who are people, I sometimes object to the term patient because it's a billing code title, is to ensure that we look at all of the systems. The reason race correction could be around for as long as it has, cause as much harm as it has, and be as durable as it has is because many people participated in it and benefited from it. As unfortunate as that is the truth. And so that entire system that brings in racism in clinical practice also brings in the failure to account for centering the actual person seeking clinical care. In the conversations, I've had to say to, docs, who've gotten the information, they've read it, they've asked their 16 questions and they've said, okay, and then they come back with another one. And I say, okay, so are we good? And they're like, yes, I've got those questions out of the way. And then the question comes, well, wouldn't this mean that we'd be transforming healthcare? I'm like, you got it. That's why we're here. We're here to transform healthcare, because the healthcare process that brought you race correction also brought you sexism. And I want to point out race correction has a disproportionate effect on gender. Why? Because women who are in the healthcare system are often cycled through more often, see more clinicians, and are more medicalized and are less believed about their conditions. And therefore, it takes a longer to do a good diagnosis and treatment plan. So this doesn't just affect all Black people the same. It affects Black people in different ways among different subgroups and among different populations. And so the part about having racism in science also brought you the lack of respect for the patient as the center of everything and the doctor as the server. Instead, we've had a system where the doctor is the center. Ta-da! and the patient is the subject. And so part of transforming into 21st century healthcare means leaving behind systems that put who were typically and historically white men to act as fathers knows best, and go back to medicine that centers on healing, where the patient knows best and is listened to. The other point I wanted to flag just really quickly is I want to say this very, very clearly. I admonish anyone who is using electronic medical records or health records to do research and to develop algorithms. And the reason was right here in this presentation. Dr. Simpson told you, Dr. Ocampo told you, Dr. Opara told you, and I'm telling you now. Why? Because race correction litters everything. It is a contaminant everywhere. There is no data that you have on Black people from clinical trials that is not filthy with race correction, either directly or indirectly, if not. Typically, the question is even grounded in scientific racism. And so when we use electronic medical records, which were never designed to be mined and profited from, we end up with even poorer healthcare and poorer clinical care as different types of tools are being developed. My area is artificial intelligence in medicine, and I am absolutely disappointed in many of the practices and my peers. So I want to point out to you, electronic medical records are not the playgrounds or the data sets to be used for clinical care. And this talk as Dr. Opara said, it goes on and on and on and on and on. And so to use those records is to commit to inappropriate and unfounded clinical practice that is non-therapeutic and dangerous science.
Thank you, Lana. The next question is that some people are benefiting from the status quo and don't want to make change. How do we address that? Which is related to, the earlier questions that we had about pushback, et cetera. So take it away.
I can just start by saying this. My approach, this is just Dr. Opara's approach in general, is I work with the blessings I'm given and don't worry so much about the ones that I'm not. My approach is usually from a Black liberatory standpoint and Afrocentric ethos that tells me that I come from a place of asset, strength, and abundance. So the thing about it is that there are more people on our side than are against us. And I believe that a lot of those folks that are already on our side, some may need some guidance, some support, some structure in order to move forward. And so usually my approach is to just work with the people that really are on our side, but just might need some additional support to, maybe a community built around them so that we can then leverage our collective strength and collective action to make change. Oftentimes people think that we need 100% to get things done, or people think we need everybody and their mama and daddy and cousin and them to get things done. I'm here to tell you that has never been the case in the history of ever, that for things to change, everybody, and that, nope. I always tell people Harriet didn't take everybody when we talk about the Underground Railroad. So yes, there's resistance, and we will strategize accordingly depending on what that resistance is and who that person is and what power they have in the first place. There is an approach to understand what not all resistance is the same or equal, and there's a critical and strategic view to lend towards understanding how to again address each resistance depending on what they are. But in general, I would say that there is more on our side than against us. And oftentimes, human mind, or some folks' mind, I don't think it's all of us. We tend to focus on where the problem is, and we spend a lot of energy there. And I'm here to tell you, look at all the people on this call. How amazing! Greater things have been done with far less number of people on this call. And so imagine leveraging all the folks just on this call alone. Really mighty things can happen. So yes, there's resistance. Always important to understand that's part of change. That's always been the case. It's not new, or However, focusing our energies and resources in organizing the coalition of the willing, and the coalition of the able, and the coalition of the interested, and the coalition of those who want to see change and be part of doing better and being better, is where I think we are focusing around. And it's amazing how people jump on bandwagons when they see a movement, coming at them. Even the ones that are most resistant end up being most powerful allies. One never knows. Or co-liberators, as I like to say, versus allies. I have some trouble with that word. So that will be the way I approach that issue. Lana, do you have a different approach?
Well, we're just about out of time. And I just want to say that's so inspiring for you to end on that note. And just both of you, Lana and Ijeoma, thank you for really showing us all your passion, because that's really what we're going to need to get through this. Reminder that this is recorded. There will be a recording of this on our website. And we will be having more talks on this topic of race correction in the fall. Have a great summer. Come back and join us in the fall. Thank you so much, Dr. Opara and Lana James.
Thank you.